So as far as an influenza is concerned, we know that this is an infectious respiratory disease, which is caused by a virus called influenza. In humans, it is usually caused by type A and type B. There is also type C influenza, which usually does not cause an infection in humans. This is what you should know regarding this. Majority of the human infection is from type 2. But this influenza is basically a zoonotic disease. This usually occurs in animals, including the birds, both the domestic birds and the wild birds, and animals, in which a most important animal which is suitable for this influenza is pigs. We'll study why this is suitable, why it is so. And this is, we know that an orthomyxovirus and an RNA virus. So there are other respiratory infectious viruses you might have known that can cause simple flu or called as common cold. So how the influenza is different from these simple cold causing viruses? Like this may be an adenovirus, this may be a respiratory syncytial virus. There are many viruses. So how the influenza is different from this common cold causing viruses is influenza is highly variable antigenetically. So its antigen, which we are going to discuss in the next few minutes, is highly variable. And compared to common cold, the influenza is more likely to have the systemic manifestations. Like the common cold, the symptoms are usually sustained to the respiratory tract. The patient may have common cold or very mild fever. Whereas if along with the symptoms of respiratory tract, the patient has systemic features like you may have a severe myalgia, severe malaise, then we need to suspect either influenza or COVID. Although it is very difficult, it is not a hard and fast rule, but it is more likely to cause systemic features compared to the common cold viruses, and it's a high propensity to cause an epidemic and pandemics. We are not in fear of an epidemic by a respiratory syncytial virus or an adenovirus. But if there's an influenza which is detected in the community, then it is a matter of great concern. We need to be very, very alert. That's how we usually differentiate between the common cold and an influenza. So this influenza occurs as sporadic, which is usually called as a seasonal flu. Or it can occur as an epidemic. And this seasonal flu involve a large community from person to person transmission. This will become an epidemic. And if this epidemic involves a very large geographical proportion, like more than 2 countries, then it can become a pandemic. A similar way in which we experience the COVID due to its very high transmissibility. So although the influenza is not as transmissible as COVID, but it is a considerable issue because every now and then we can experience a new strain in the community, which is very different from the previous existing strain for which we might have not immunized. That's why this becomes important. So this seasonal flu is very, very important. It is going to occur in both the northern hemisphere and the southern hemispheres of the geography. The northern hemispheres in which India is situated, the majority of this flu outbreak usually occur in the month of October, or you can say from November to February. In the winter months, there's a timing of the seasonal flu of influenza. That's why it's usually advisable to take influenza vaccine in the month of August, starting from July to September. It's the best time to take an influenza vaccine as it is given annually. And it is not a new virus. We know that the first outbreak, the clinically demonstrated first outbreak was around the early 19th century. But there are some reports in the books written by the Hippocrates that as early as in the 15th century, there were an outbreak which were similar to the influenza, like patient used to have cough and coryza, progressing into severe pneumonia and air hunger, and ultimately causing death or an increased morbidity. So this is a similar photograph which was described in the history as the gasping operation, the pandemic of gasping operation. But as far as the humankind which has experienced the greatest memorable event as a flu outbreak or pandemic was the Spanish flu in 1918. Although this was tested retrospectively in 2005, only in 2005 we got to know that the 1918 outbreak was due to influenza. So in 2005, scientists dig the bodies which were died during this pandemic, and they tested for the sample which was positive for the human influenza. So it was the most severe influenza outbreak of the 20th century. There were a huge number of deaths, which was comparable to the bubonic plague. And most common cause was pneumonia, and the deaths were mostly in the healthy adults. So till now we have come so far that there have been 4 or 5 big pandemics here. So this 1981 Spanish pandemic was the first pandemic in the early 19th century. So for the next 20-30 years, this H3N1 remained circulating throughout the world. Then occurred a different pandemic, an Asian pandemic, which was due to a different serotype of a human influenza called as H2N2, also called as an avian influenza. This was due to genetic reassortment occurring in the avians. So this occurred in 1957. So again in 1957, after a decade, there came a different serotype of an influenza called H3N2, also called as swine flu or pig flu, or WHO prefers the name of Hong Kong flu. The H3N2 is usually called as Hong Kong flu because it was first detected and created a massive pandemic of an H3N2 in the year of 1968. And what happened after this is, after 1968, both H1N1 and H3N2 remained circulating throughout the world, causing multiple flus. But in 2009, a very important epidemiological thing occurred. What occurred is there is a subtype change in the serotype. The H1N1 77, which was in the circulation, was replaced with an H1N1 09. So this was the major antigenic shift, which caused again a pandemic of H1N1 in 2009. So after this, there are multiple types of H1N1 are in circulation. In the meanwhile, the other influenzas are also got detected, like influenza B. In early 1980s, there were 2 varieties of influenza B were detected. One is Yamagata, another one is Victoria. So this is basically an epidemiology. So the world can have again pandemics in future. We cannot get away from this until and unless we find a universal vaccine for influenza, which is a very most difficult thing at present situation. So this is the simple history in which we should know that what is influenza, what is occurring in this. So if you go for the virology aspect of the influenza virus, so this is nearly spherical shaped, sometimes called oval shape, with a size of 80 to 20 nanometer, and it is a little bit pleomorphic. The shape may change with the variant forms. The basic structure of this contains a very 4 important things. One is there are 2 types of proteinaceous protrusions on the viral surface. The one is called hemagglutinin, another one is called neuraminidase, a very, very important thing. And this lipoprotein envelope also contains an ion channel, which is also called as an M2 ion channel, which is very important for the action. And as a genetic material, they have an RNP, which is a single-stranded RNP with a negative sense. This is the basic structure of the influenza virus. So this is a negative sense. To differentiate it from COVID, COVID was a positive sense RNA, and both were single-stranded. And the genome here is segmented into 8 segments. That means it can synthesize 8 different type of proteins. Among this, one is hemagglutinin, one is neuraminidase, another is H channel. There are 5 different things. If you see the COVID virus genome, which had 28 genetic segments, so the propensity to produce the more number of antigens was highest in COVID. And this genetic material is covered by the envelope, which has got an inner layer of protein and outer layer of lipid with a lipoprotein membrane formation. And there are 2 projections from the envelope, as I said. One is the hemagglutinin, another one is the neuraminidase, and there are different types of these protrusions depending on the subtypes. So this hemagglutinin subtypes are categorized into 18, and the neuraminidase categorizations are 11. So you can have a multiple combinations of H3N1 existing or in future appearing. So like H3N1, that simply means type 1 of hemagglutinin and type 1 of neuraminidase. H3N2 basically means type 3 hemagglutinin, type 2 neuraminidase. So the various combinations can occur due to the genetic reassortment. So this is a very, very important thing here. And what is this ion channel does is, ion channel is very important to maintain the pH across the viral envelope during the cell entry of an infected cell. To virus to survive, it is very important to have an acidic medium inside the cell. So once the virus enters the cell, I'll show a picture you later. This will be endocytosed, and this ion channel helps to maintain an acidic environment inside the cell. So this is a very, very important thing. And the drugs which you might have heard called an amantadine targets this ion channel. Amantadine acts through targeting this channel. This is a very, very important thing. As I told you, compared to the common flus viruses, the influenza has got a remarkable potential for the antigenic variation. Its antigens keeps on variating from one serotype to another serotype. So these antigenic variations occur in both the surface antigens. It can occur in the hemagglutinin. It can also occur in the neuraminidase, independent of each other. Sometimes the neuraminidase may not change, only hemagglutinin may change. Sometimes neuraminidase may change, hemagglutinin may not change. Sometimes they both may change. So among this antigenic variation, there are different types. One is called an antigenic shift, and another one is called an antigenic drift. I think you all have heard this very famous phenomenon. To simplify this, antigenic shift and antigenic drift is very, very important. The drift means a very small mutation. This will not change the organism, or this will not change the serotype. There might be some minor differences in the genetic component. Whereas an antigenic shift is nothing but a genetic reassortment. You have got a type A serotype and type B serotype, which together may produce an entirely new serotype called type C. This is for an example subtype. So an antigenic shift is a very, very important thing in causing pandemics. We might have not at all exposed to this new serotype. We might have not at all vaccinated for this new serotype. So this is going to be causing a havoc in the community. But drift is easily controllable. Since there are only minor changes, it will cause a simple flu outbreak. We need to be careful only in the high risk population. Otherwise, it will not cause any pandemics. There are some differences which we should know. As I told you, shift is a major antigenic change, whereas drift is a minor or a simple antigenic change. The shift leads to a formation of an entirely new subtype. To give an example here, for example, there is a human and there is a bird. There is one subtype called an X, which is circulating in humans or which has been there, and Y is circulating in birds. Suddenly, the pigs come into the picture. If they get exposed to this, so these X and Y, they together are inside the pigs. So in pigs, there might occur a genetic reassortment, which might lead to production of a new virus called Z. So that's why the pigs are usually called as a mixing vessels in influenza. Pigs are very, very important and the most important reasons leading to the pandemics. So shift is a very major antigenic change. Hence, it might give rise to a pandemics which occurs very irregularly and unpredictably, very, very important. Whereas it is a minor change. It just forms a new strain of a virus, but not a subtype. Hence, it will just cause an epidemic in between the pandemics, but does not cause a single pandemic. Since drift is a very minor change, it occurs very frequently, whereas shift occurs once in a while. Like if we can say the 2009 pandemic might be due to an antigenic shift. And to have an antigenic shift, we need one or two different types of viruses getting involved to produce an entirely new strain. Whereas a single virus can have many drifts over a period of time. Since it is a shift, since there is a formation of a new complete serotype, so there is usually a large change in the nucleotides of the RNA, producing an entirely new type of an antigen for which you are not at all exposed or for which you don't have antibodies at all. Whereas a drift is a small mutation. As I told you, shift is due to a results of genetic reassortment between the different subtypes. As I told you, as given example of avian influenza. Whereas drift occurs just due to an accumulation of point mutations in the gene. For example, there is an H3N2 in the pigs. So these pigs go on transmitting to other pigs, and this H3N2 over a period may have small change in their genome. So that is what is drift. So I think I have made clear what is shift and what is drift. Shift is very important. Shift is a major antigenic change. Shift is a large change. Shift leads to formation of a completely new virus for which we are not at all exposed. Shift is very difficult to treat, and shift can give rise to pandemics. So as I told you here, there may be some bird reservoirs and the swine reservoirs. The swines are usually called as the mixing vessels. I gave an example for this. So the transmission can occur between the animal to the human with the capacity to cause a human disease. So let me take an example of an antigenic drift. For example, there is an H1N1. So which has over a period of time might have a little change in the genetic genetic component, so undergone a drift. So suddenly it will infect the human, which will create a small epidemic or might be a sporadic flu event. If there is an antigenic shift, this will become a huge pandemic by the interhuman and human-to-human transmission. So the outbreak may lead to an epidemic. An epidemic may lead to a global outbreak called a pandemic. That's why the WHO categorizes the stages of influenza as stage 1. Stage 1 in which the human is not involved. The organism is just either in the bird or in the pig. And there is an animal to human transmission occurring. This is term called as stage 2. Stage 3 is called as a limited human-to-human transmission. If it is a antigenic shift, this will stop at here. Sorry, drift. If it is an antigenic drift, it will stop here. If it is an antigenic shift, this will have an ability to cause stage 4 of the disease, causing a pandemic or an epidemic. When this gets involved in more than 2 countries, this is called as a pandemic. Very, very important. When COVID-19 outbreak occurred in China, it was only depicted as an epidemic, whereas early January, once it spreads into more than 2 countries, the WHO declared it as a pandemic. So this is how you remember the stages of these outbreaks. As I told you, there are 3 types of influenza viruses, basically influenza A, B, and C. C rarely infect humans. The influenza A is of massive importance because it occurs in variety of organisms. It can occur in humans, pigs, horse, birds, marine animals, anything. But whereas human influenza B occurs only in humans. The influenza B and influenza C will not produce any major antigenic shift. Only minor drifts are there. Whereas influenza A is very notorious in causing antigenic shifts. And hence, a very important type of influenza causing a pandemic. A very, very important thing here. And if you know, if you go for the structural differences, there are minor structural differences here. The influenza A, as I told you, there is a genetic component, there is a lipid envelope, there is an ion channel, there is an hemagglutinin, and then there is neuraminidase. If you take this influenza B, it is almost similar to the structure, the hemagglutinin and the neuraminidase. That's why if you take the neuraminidase inhibitors, they can cover both influenza A and influenza B. Whereas if you take the influenza C does not have the antigenic projections like A and B called hemagglutinin and neuraminidase. That's why the neuraminidase inhibitors cannot be used for influenza C. Whereas influenza C also has an M2 receptor channel. The amantadine can be used for influenza C. So the question might come, which of the drug is used for influenza C? So the options are oseltamivir, zanamivir, perimivir, and amantadine. So the answer should be amantadine. This is how it is very useful to know the structures. So how the transmission and pathogenesis occurs. Here is a very, very important person. Here there is an infectee, and here there is a susceptible person. So what happens during an acute viral infection episode is an individual, for example, here he is an infector, which is depicted in the red color. He may shed the viruses in his exhaled breaths and when he coughs, when he sneezes. So this exhaled product contains many microparticles called droplets and aerosols. So these aerosols may also contaminate an existing surrounding person or surrounding structures like fomites. So this exhalation component can have 2 types of transmission. One is aerosol, another one is droplet. And droplet is a little bit of bigger size. Aerosol was a little bit of smaller size. So it is the size of the particles which determines whether it is a droplet or aerosol. So if somebody asks you among the aerosol and the droplet, which contains more number of viruses, so the answer should be droplet, because droplet is bigger in size. Hence, it contains a large amount of bacteria in their secretions. Whereas aerosols, since they're very small, they can travel in the air for a longer distance. So, which carries a longer distance transmission is the aerosol. The aerosol can transmit for a longer distance, whereas droplet contains a very high number of organisms. And this is same for all, including COVID. And in general, what happens is if a susceptible individual is very close to the infector, he can have a very short range of transmission, which can occur from the droplet, from the aerosol, or it can occur in the direct physical contact, or it can also occur by the indirect physical contact like the FMAS. This is very, very important, right? Transmission. Whereas if the infectee is at a distance from the infector, the long range transmission can occur by the aerosols. As I told you, since aerosols are smaller in size, aerosols can travel to a little bit longer distance compared to the droplets. So the long range of transmission can occur via the aerosols and also through the indirect contact of the fomites. So this aerosol transmission also depends on the surrounding weather and the temperature. If the weather is very helpful for the viruses, they can circulate for a very long time also. And as far as this fomite is concerned, whenever this droplet or aerosols falls on fomites, for example, a doorknob or a table, etc., it may evaporate, whereas viruses may remain on the surface, which are transmissible. So this is a very, very important type of transmission. That's why the physical measures to be started much earlier than the chemotherapy or the drug therapy to prevent the transmission from one person to another person and from the fomite transmission. And again, it is very helpful for the entrance also. The question might come, which is not responsible for a long range transmission of an influenza? Option A, droplet. Option B, aerosol. Option C, mobile phones. Option 4, doorknobs. So the right answer here will be the droplet, because droplets are heavy in size. They soon fall to the ground. They cannot travel for a long range. That's why long range transmission is not caused by the droplets. It's a very important concept in the transmission here. So as I told you, that both the short range transmission and the long range transmission are important for the public health measures during the early stages of the pandemic, wherein the communities can adopt to reduce the respiratory virus transmission. In the COVID era, this was terminated as COVID appropriate behaviors. You might have heard this terminology. The most common reason for the second wave of COVID was inappropriate COVID behavior. People forgot wearing masks, people stopped washing their hands, etc. So these can be the personal protective equipments, which usually done by the face covering by the general population. Whereas if the person is a healthcare profession, he can go for an entire personal protective equipment. And very important in the physical transmission inhibition is the hand hygiene, because the viruses get simply deactivated by just washing with either soap or preferably an alcohol-based solution. A very, very important thing, similar to COVID. And the surface cleaning is very, very important. Clean the surface daily, clean the hospital area freely, clean your USG machine, clean your X-ray machine, clean your table, clean your chair just by the white cloth. And there are some air dilution techniques by the ventilation and directional flow, like you need to have a cross ventilation, the well-ventilated area, the flow should be unidirectional, etc. These are very, very important for the overall ventilation of the existing community. So once this virus enters into the human, this usually infects the epithelial cells of the respiratory tract. This is a very, very important thing. The harboring cell is an epithelial cell of the respiratory tract, very rarely GI tract. So here if you see an influenza virus, which is having two projections, one is the neuraminidase, another one is the hemagglutinin, getting attached to the specific receptor. These are also called as salicylic acid receptors. And if you look carefully this diagram, it is getting attached through an antigen called hemagglutinin. So hemagglutinin is very important in cell entry. Or cell entry is mediated by which antigen? It is mediated by hemagglutinin antigen. So once this virus gets attached to this specific receptor, also called as sialic acid receptor, or also called as simply galactose type of receptor, gets endocytosed inside the vacuum particle, and here the M2 channel maintains the acidity, which is responsible for the growth or the maintenance of this genetic environment. Then the fusion and coating occurs. The viral RNA enters the nucleus of the host cell. This viral RNA starts to synthesize proteins, and there might be a formation of new viruses, and these new viruses gets released into the circulation. So if you look carefully, to exit from the cell, very important antigen which is responsible for is the neuraminidase. So neuraminidase is important for exit from the cell. A very, very important thing. So the hemagglutinin is important for cell entry, whereas neuraminidase is important for exit of the cell. This is very, very important. And I specifically mentioned here that influenza A virus binds to this specific receptor called sialic acid receptor or galactose type of receptor. Why this is important, why I am telling this very tiny particle is, there are mainly two types of viruses. One is called alpha 2,3 sialic acid receptor. Another one is called alpha 2,6 sialic acid receptor. So this 2,3 sialic acid receptor is present in birds' respiratory tract, whereas this 2,6 sialic acid receptor is situated in humans. Humans does not have 2,3, birds does not have 2,6, whereas pigs have both. So that's why pigs can get infected with a very variety of types of the influenza where the genetic reassortment can occur. That's why the pigs are called as mixing vessels. They will mix these two viruses and create a new one. As I told you here, once the epithelial layer is infected, the cell exits from the epithelial cell. That epithelial cell get lost, or it loses its function. So whatever the innate immunity, the first immunity in the respiratory tract is lost immediately. So the mucociliary function is lost. The mucociliary function is lost. The antimicrobial peptides are not secreted. The mucociliary clearance is lost due to a de-epithelialization of the respiratory tract. So this de-epithelialization makes a loss of an innate immunity, and this exposes a variety of bacteria to have a secondary infection. So this is a very important mechanism here causing an infection. This influenza usually remain situated to the epithelial layer. It usually does not cross the barrier or the basement membrane to involve the subepithelial layer. Even in the respiratory tract, lower respiratory tract, even in the lower respiratory tract, the influenza virus remains situated only for the epithelial layer. It does not go beyond the subepithelial layer. Whatever the thing which is occurring in the subepithelial layer in the primary viral pneumonia is due to cytokines secreted as a protective mechanisms. So this is a very, very important thing layer. And this de-epithelialization and the loss of immunity occurs as early as within hours after having an influenza infection. So within hours, your entire respiratory tract epithelial layer may get denuded, and may expose your respiratory tract for the secondary bacterial infection. Very importantly, the Staphylococcus aureus and the Pseudomonas, very notorious organisms to treat. So to deal with the clinical features, as we know, it usually starts with a flu with an incubation period of 1 to 4 days or with an average of 2 days. Whereas in COVID, we studied that incubation period may have or may expose or may prolong till 2 weeks, 14 days. Whereas incubation period of influenza is very short, it's for only 2 days. Whereas if you see the time of onset, time between the onset of the illness among the contact is 3 to 4 days. So if you have got a family member from an influenza, within 3 to 4 days, you are going to develop symptoms. Usually it does not spread after 4 days. That's what the meaning, that's what we should know here. So the usual symptoms, if you want to see here, are the respiratory symptoms. That is a simple cold plus coryza plus pharyngitis with sudden onset of high-grade fever. This is the usual presentation of influenza outbreak. That's why it is also called as an influenza-like illness. The clinical definition of an influenza-like illness, an acute febrile illness with 1 or 2 upper respiratory tract manifestations. The sore throat can be pretty problematic here, or the pharyngitic, the pharynx will look red hot with a severe pain sometimes. And there are a variety of systemic manifestations. This fever may progress with associated symptoms like headache and confusion. The respiratory tract may have a nasal congestion, the sore throat, and a dry, irritant cough. Although GI manifestations are very rare, unlike COVID used to have frequent GI manifestations. Although we cannot directly compare influenza with the COVID because the population is very different here. And very important manifestations of influenza is the muscle ache. People usually address that they feel very fatigued, they feel severe pain. Sometimes there may be a muscle tenderness also. In majority of the people, it remains at this stage only, usually does not progress into the lower respiratory tract or an extrapulmonary area. In only some people, it progresses to the lower respiratory tract or to the extra pulmonary sites, causing complication. So if you see, the most common complication of an influenza is pneumonia. So this can be again the entrance question. The most common complication of influenza is pneumonia. In some children, it may also cause a laryngobronchitis called croup, or sometimes otitis media can have both coexisting viral plus bacterial etiology. Once it can progress, can present as pneumonia, or it can exacerbate a chronic lung disease, be it an asthma, be it a COPD or an ILD. So very, very important. There are other extrapulmonary manifestations of influenza. If you see the neurology, it can cause the febrile convulsions or an increased frequency of seizures in a pre-existing seizure disorder, which can be a manifestation of self-limited encephalopathy. These are not my terminologies. I am giving the standard terminologies. So patient can throw seizure if he is the known case of febrile convulsions, or if the patient is a known case of seizure disorder, may sometimes presents as just an increased risk or increased episode of seizures. Earlier times, we used to have race syndrome due to use of an aspirin in controlling fever. And nowadays, it has been reduced due to the less usage of aspirin during the episode of fever. Sometimes it may cause an aseptic meningitis or an encephalitis or an encephalopathy kind of thing. It can also cause transverse myelitis, which can be immune-mediated or by the direct involvement of the virus. It can also cause post-infectious acute demyelinating encephalomyelitis, which have got some typical manifestations in CM, contrast-induced MRI, involving the subcortical gray matter and white matter. And it can also cause a very famous Guillain-Barré syndrome. So the influenza virus and the influenza vaccine both are implicated in causing GB syndrome. This is a very, very important thing. As far as cardiac manifestation is concerned, the pericarditis and myocarditis can occur, although very rare. It can exacerbate your heart failure or precipitate an arrhythmia if you're at risk. And over a period of observation, it has been seen that during an episode of seasonal flu, the cardiovascular events number increases. Although direct causation was not established in this, but it has been told that during an episode of either an epidemic or a sporadic or a pandemic influenza, the amount of CV diseases increases. And the musculoskeletal, the myositis can occur. The myositis is very common with influenza B more than compared to influenza type A, where it can progress into rhabdomyolysis. So this can be again the entrance question here. As far as pregnancy is concerned, yes, it is a very considerable issue. Pregnancy has got both maternal and fetal complications, the risk of IUGR and the prematurity, including the low birth weight, and the disease can be very severe. That's why pregnancy is usually considered as a high risk group for influenza. This is a very, very important thing here. As I told you, the most common complication of the influenza is pneumonia. This pneumonia usually occurs in 3 patterns. Either it can be a primary viral pneumonia caused by the influenza, or it can be a secondary bacterial pneumonia, or it can be a mixed viral and bacterial pneumonia. So how do you suspect whether it is a primary influenza pneumonia or what? As I told you, the patient with influenza usually present like an ILI, where patient may have a sudden onset fever plus symptoms suggestive of URTI, and these symptoms usually improves in less than 48 hours or sometimes within 3 to 5 days. If this patient is not improving, like for example, you have got a suspected patient who have got a persistent symptoms. Sorry for spelling mistakes. If we progress to have a persistent symptoms and signs, even after diagnosing from influenza for 3 to 5 days, then you should suspect the primary viral influenza. Fever is not reducing, patient is having cough continuously, patient is looking sick, patient seems to have a malaise, dehydrated. You need to suspect a primary influenza pneumonia. When do you suspect the secondary bacterial pneumonia is when there is a biphasic illness. For example, a patient has an influenza and starts to show an improvement. If this improvement is followed by a relapse of a fever with increase in cough and increase in production of purulent sputum. So if there is a biphasic pattern, you should suspect secondary bacterial pneumonia. Or commonly it can be a mixed viral and bacterial, where the patient may have a gradual progression of the symptoms, or there might be a transient improvement with the future worsening. So you need to know how to differentiate between these two, because it is important to consider antibiotics in the secondary antibacterial pneumonia, whereas antibiotics may not have any role in the primary influenza pneumonia. Here you have got a question. Which complication is more commonly associated with influenza B? The options given here are pneumonia, myositis, cytokine storm, and pulmonary embolism. They are not asking which is the most common complication of the influenza. They are asking which is more commonly associated with influenza B. We know that as I told you, myositis or rhabdomyolysis may be progressing into acute renal failure. Any option can be situated here. Is usually caused by influenza B subtype, not the type A. Both in all these pneumonia, cytokine storm, and pulmonary embolism are common with influenza A, whereas the myositis, rhabdomyolysis, and the acute renal failure are common with subtype B. As I told you, there is a particular group which is at risk of complications, a very, very important thing, and must know in influenza. If you don't know anything, it's okay. If you know which are the complicated groups, it is more than enough. Children which are less than 5 years, preferably less than 2 years, and children who are more than 65 years. So extremes of the age. This is and difference with the COVID. In COVID, yes, age more than 65 is the risk factor, whereas children less than 5 was not the risk factor. Children usually does not have a severe disease in COVID, whereas influenza, both the extremes at risk. You can club it as one. Next is a pregnant woman. Next is we can take as the hospital workers. Next, some ethnical groups or ethnical groups and some medical diseases. So there are 5 groups of risk factors. One is extremes. Second one is pregnant women. Next is the hospital workers or the healthcare facility workers. And next, some ethnical groups like non-Hispanic blacks, and the American Indians, and Alaska Native person. It may be due to some ecological differences. So they are at particular risk for complications, and people with medical condition, any medical condition, the heart disease, kidney disease, liver disease, diabetes, any lung disease, the blood disorder, which is specifically the sickle cell anemia, the neurological and neurodevelopment diseases, and immunosuppressions, be it an HIV, on drugs, on steroids, everything. And children who are on less than 19 years, who are on long-term insulin therapy. So this is a homework for you guys. Give me the indication for long-term aspirin therapy in children less than 19 years. This is a homework for you. And people with class 2 obesity. Class 2 obesity is more than 30 as far as India, I'm telling Southeast Asia Pacific region. 30 kilo per meter square is a risk factor for the complication. So all these, if at all I see a person with influenza having these risk factors, I will not sit quiet. Don't relax. This is a don't relax group. You need to admit that even if you don't have any symptoms. So if you see some amount of difference between the influenza and COVID, so the incubation period is short in influenza, but it can be prolonged in COVID. So person can spread the virus even in the incubation period. So that's why it was more transmissible. And if you see the R0, the ability to transfer, the number of people you are likely to infect is highest in COVID. It is more than 2, and it is less than 2 in case of influenza. The transmission is similar, both as a respiratory droplet and the aerosol. The symptom-wise, influenza is pretty abrupt onset. COVID, it usually mentioned as slower onset, but it's not a hard and fast rule. They can also have an abrupt onset. COVID can have anything. And symptoms, it is no much difference. They can have fever with a systemic involvement with a respiratory predominance, and symptoms are more common in children. Whereas in COVID-19, majority did not have any symptoms. Symptoms were very variable, and one peculiar symptoms everybody of you might have know that this ageusia and anosmia are usually not seen in influenza. If a person complains with the influenza-like illness, the loss of taste and loss of smell, you need to suspect COVID. Although, again, I'm telling this is not a hard or fast rule, but yeah, there is a difference in the loss of taste and loss of smell, which is not seen in the influenza. The hospitalization rate was double-digit in case of the COVID-19, whereas it is single-digit in influenza, less than 2%. The mortality rate was more than 1%. The global 4.5%, although US, they have given it a very less number, very difficult to believe this. And the risk population is almost similar, except COVID-19 does not cause complication in children, unlikely to cause COVID per se. They may have this macrophage activation syndrome, but per se, COVID is less complicated in case of children. We don't have any treatment for the COVID-19 like directly acting antivirals, although remdesivir you can say, but for specific drugs. And vaccine is available for both at present situation. Again, this is a simple diagrammatic representation just to remember. How will you diagnose the influenza? So in a community with an influenza activity, any patient coming with an abrupt onset of fever, cough, myalgia is influenza. You need not test. You can directly start treatment. This is a very, very important thing, considering it's an uncomplicated influenza. So it is very difficult when there is no outbreak, but you get an ILI. To have a high suspicion, it is very, very important. Sometimes what happens is if you have a patient who is immunosuppressed or a very old age patient, influenza should be suspected even with the milder systemic symptoms, with or without fever. Like old age people may have just two complaints. One is a decreased physical activity and decreased appetite. This is a very, very common thing. As in children don't have, they may not have any other symptoms other than excessive crying. Sometimes parents bring children that he is just crying and you don't know what is going on with the patient. Similarly, in very old age people, the family attendants may bring the patient just with complaints of decreased physical activity. My father is not going for a walk, he's just drowsy, he sits, and he has got a decreased appetite. These can be a variety of manifestations in case of old age people. This can be UTI, this can be hypothyroidism, this can be any pneumonia, this can be encephalopathy, this can be dyselectrolytemia, this can be anything. Similarly, if you see during the community activity of an influenza, if you see an immunosuppressed patient or a very old age patient, even with the milder symptoms or a non-specific symptoms, fever may not be there, you need to suspect an influenza in these groups. As I told you, for sporadic cases of an ILI, yes, you need to establish a definitive diagnosis to halt the community spread. Otherwise, during the community activity, you need not test. So what are the tests which are available for us? The recommended tests are the conventional molecular assays. The molecular based tests are usually recommended, in which the technology used is the polymerase chain reaction, that is RT-PCR. So this is pretty rapid. It gives results within 1 to 8 hours. And if you can have the multiplex PCR also, multiplex PCR means here in a single test, you are testing for different types of viruses. You can test for influenza, you can test for COVID, you can test for adeno, you can test for respiratory syncytial, you can rotavirus. So many of the viruses are checked together in multiplex PCR. That is the advantage. So both the techniques are same, but RT-PCR is a single agent, whereas multiplex RT-PCR is for the multiple agents. So these have got very high sensitivity and also very high specificity. And another important is they can differentiate between the type A and type B, and also subtypes of type A. They can differentiate. Whereas there are some rapid molecular assays are available, which can give results within 15 to 30 minutes. Also very high sensitive and specificity, but they cannot differentiate between the subtypes. They can differentiate between type A and type B, but subtype differentiation is not being done. And there are some additional tests like the COVID. We have rapid antigen kits where the results are available in hand within 15 minutes. Have got low sensitivity. That means the false negatives are very, very common. And in multiple classes, I have told you this, the sensitivity of a test is ability to rule out the disease. So if it is low in sensitivity, that means it is not good in ruling out the disease. So if you have a negative test, it can still be positive because of low sensitivity, but it has got a very high specificity. That means if it is positive, then you need not check anything. You need not go for an RT-PCR if it's positive. Many of the times I have seen the rapid test is positive, then you again sent it for an RT-PCR. This is very wrong. They are very highly specific tests. the ruling in is very accurate in this. Whereas if it is negative, especially in the existing community spread, and you are having symptoms, if your antigen is negative, you need to be confirmed by an RT-PCR. It will be similar in case of COVID also. You have also got viral cultures not used routinely, only for the research purposes or to test for the viral resistance to the antivirals. The culture is used. You have got shell culture, which reports are available within 1 to 3 days, whereas isolation in cell culture is a little bit time consuming, but they have got a very high specificity. But time consuming, so cannot be used for the clinical management. So the best is the RT-PCR. So we know what test to be done, but what is a sample to be done. The ideal sample is the nasopharyngeal sample. Please remember this. So here I can throw a question here. Which is the best specimen for influenza testing? Option A, nasopharyngeal specimen. Option B, nasal specimen. Option B, nasal and throat specimen. Option C, throat specimen. Here, the nasopharyngeal specimen is the best. For example, the question can be asked in a different way. Which is the best specimen for the influenza testing? Option A, nasal. Option B, pharyngeal. Option C, RT lavage. Option 4, nasal plus throat. So in this situation, the answer is nasal plus throat. So always go for a nasopharyngeal specimen, not the throat specimen. If nasopharyngeal specimen is not able to obtain, then get both nasal and throat specimen. Don't take a single nasal or a single throat specimen. This is a very common mistake. You might have seen in the COVID also, they usually take 2 specimens, one from the throat, one was a nasopharynx. But ideal choice of specimen is the nasopharynx. If nasopharynx is not available or cannot be done, you can take both the nasal and the throat specimen. So the specimen collection also, they are giving the importance to use this flocked swabs so that the yield is very high. You also got commercial available flocks, which can be used in the home also. What happens is traditional swabs was the sample used to get trapped in the swab fiber, so the yield was less than 10%. Whereas nowadays we have got nylon flock swabs where the yield is increased up to 90% due to availability of these flocks. The organism or the material does not get trapped inside this. Coming to the treatment of influenza, how you want to treat the influenza here is first is the site of treatment. So what are the indications of the hospitalization? All the influenza patients I may not hospitalize, yes, but you give them all the COVID appropriate behavior. Don't step out from the home, remain contained in the specific area, don't sneeze here and there, etc. Frequent hand washing, use of mask, all these are given for the simple uncomplicated influenza patient. Whereas if the patient is sick, like they have got a severe dehydration, any sickness, they have got respiratory distress, hypoxemia, impaired cardiopulmonary circulation, these can be considered for the hospitalization, and patient with altered mental status can also be considered. But even if the patient does not have any sickness, the high risk population, people with increased risk of complications, as I discussed, there were 5 categories. If you remember, the extremes of age, the pregnant woman, healthcare workers, some ethnical predisposition, and any coexisting medical disorder, any organ disorder, heart, kidney, liver, lung, immunosuppressed patient, children less than 19 years with long-term aspirin therapy, and the patient of class 2 obesity, patient of diabetes, they need to be very carefully observed. Like even if they does not have any symptoms, if they have influenza, you may admit them for the observation, as they are very likely to get worsen within a very short period of time. Or if the physician seems that this patient may go into an uncertain clinical trajectory, like if the patient is staying alone, even if it does not have any complication, patient is staying alone, very old age, or sometimes a mild mental retardation, unable to take self-care, you may consider the admission. Coming, how will you manage an outpatient management of influenza? Like patient has got an uncomplicated influenza, does not have any sickness, does not have any risk factors. So how will you manage this patient? So if the patient has a symptomatic influenza and who does not warrant hospitalization, you need to know whether does he have any progressive illness and whether he have any risk for complications. As I told you, if there are risk factors, then you need to administer the antiviral very promptly, irrespective of the duration of symptoms. Please remember here. 4 days back only, I had a patient who was admitted in a small nursing home with DKA. This was the last week example I'm giving you. The patient was admitted in a hospital in DKA. The patient did not get improved, starts having severe fever after 24 hours. They got an X-ray. They had a big pneumonia. The patient was referred to our hospital. The patient was received. Patient was still in DKA, still continuing in Antigenic gap metabolic acidosis. The patient had a pneumonia. Since the patient was a resident of Bangalore, we tested for influenza. Influenza was positive. So this, all the duration was already 5 days. And my duty doctor argued that influenza treatment does not have any role if we give more than 48 hours. Yes, many of the people believe this. I agree. But I will not follow this for a sick patient or a person with risk of complication. Only if a patient is uncomplicated, influenza does not have any risk factor, does not have any progressive illness, more than 48 hours, I will not suggest administering the antiviral treatment. If the patient is at the risk factor, having the progressive illness, I will consider for an antiviral treatment irrespective of duration. This is a very, very important thing you need to know. Especially during the time of an epidemic, you need to consider this. Again, if does not have any risk factor and symptoms are more than 48 hours onset, you may consider leaving the patient just the symptomatic treatment. Whereas if less than 48 hours of the symptom onset, you can try the antiviral drugs. And what are the antiviral drugs you know of to treat for the influenza? We have got 3 classes of drugs. One is the neuraminidase inhibitors, which are also called as exit inhibitors. So they inhibit the virus exiting from the infected cell. And we have got an endonuclease inhibitor, which is a very new drug called baloxavir. Then we have got old drugs called adamantines, the amantadine and rimantadine. They are M2 ion channel blockers. So over a period of time, there has development of a huge resistance for these adamantines. So they are usually not used nowadays. So what is another indication of amantadine? This is again a question for you. I think you know this. So we are left with mainly 4 drugs: oseltamivir, zanamivir, peramivir, and the baloxavir. So we need to know detail about these 4 drugs. To know this, let us take few questions. So which mechanism among these appears to be the most suitable in the treatment of influenza? By blocking virus entry into the cell, by blocking virus exit from the cell, by blocking ion channels on viral membrane, by inhibiting viral replication. So Which you think is the right answer here? The right answer is by blocking the virus exit from the cell. The virus entry is usually mediated by heme agglutinin, and we presently does not have any heme agglutinin inhibitors. We have only neuraminidase inhibitors, and we know that neuraminidase blocks the exit. That's why the most suitable mechanism of treatment is by blocking the virus exit from cell. By blocking ion channels on the viral membrane, we do have adamantines, but as I told you, there is a huge resistance among the influenza for amantadine. So that's why it is not used nowadays. I think nobody has seen this amantadine. Which among the following is not used in severe influenza? Again, this is a question. Remember the question, you can have the answer later. Which among the following is not used in the immunocompromised host? Which among the following is used if the oseltamivir resistance is suspected? This is a very important question. Which among the following cannot be used in pregnancy with influenza? And again, question is which among the following is not used in the chemoprophylaxis in contacts with influenza? This is also a very important question. So this is not difficult. Let us go one by one with the drugs. Oseltamivir, we know this is a very efficacious drug for the treatment of influenza. For the treatment purpose, it is used as 75 mg twice daily, given orally for the 5 days. For the prophylaxis dose, same dose is used once daily for 7 days in case of post-exposure prophylaxis. This is very, very important. It is BD dosage for the treatment, whereas it is OD dosage for the prophylaxis. And it is 5 days duration for the treatment. It is 7 days duration for the prophylaxis. This is very, very important. It does not have any contraindications. It can be used in children, although we cannot use in less than 14 days infancy. We can use after 14 days. It can be used in pregnant women. It can be used in immunosuppressed. It can be used in old age people, etc. Only place where it cannot be used is when you have got a very high resistance to this drug. Very, very important. Next came zanamivir. Zanamivir was an intranasally given antiviral or anti-influenza drug. So it is used as 10 mg BD for 5 days. So it is available as a disc inhaler. Of a technique to deliver drug to the intranasal route. So this is available as a puff, like an MDI. So each puff will give you 5 mg. So you need to take 2 puffs 2 times daily for 5 days. This is the treatment of method in case of zanamivir. And again, it is given as 2 puffs once daily for 7 days in case of post-exposure prophylaxis. Whereas zanamivir, remember, cannot be used in a patient with asthma and a COPD or any bronchospastic disorder. This zanamivir may stimulate a severe bronchospasm. That's why it's been exclusively contraindicated. And it has been told that you cannot use this for the severe influenza also, because it is very difficult to administer in a patient who is sick, and patient on ventilator also it cannot be used. Next, coming to peramivir, it is the only parenteral anti-influenza drug available. It is given as a single dose. (600 mg). You usually get 1 ampule of 200 mg in case of peramivir. In the package, you contains 3 ampoules, 200 of each, so constituting 600 mg. And don't give Paramivir on a blind basis. Paramivir, reserve it only for the patient who cannot tolerate oral or inhaled agents. So Paramivir is not a first-line drug. It is usually a second-line drug. Although if you see the FDA guidelines, they approve for uncomplicated influenza. They given the approval for the uncomplicated influenza as a single dose. Don't give it for a uncomplicated influenza. Prefer oral drugs like the oseltamivir. In case of a complicated influenza, if you want to go for a parenteral therapy, give Paramivir, but practical to consider it for a 5 days duration, not a single dose duration. Although FDA does not mention multiple doses of Paramivir, but many of the clinicians, including the intensivists, during the influenza, if they're not giving oseltamivir and have chosen Paramivir, they usually give it for 5 days, not a single dose. This is the important thing about Paramivir. And another important thing with Paramivir is Paramivir cannot be used if there is an oseltamivir resistance. So it has got a cross resistance or a shared resistance with oseltamivir, whereas zanamivir does not have any shared resistance. That's why if the patient is resistant to oseltamivir, the drug which should be used is zanamivir. This is a very, very important thing. Next, coming to the Biloxavir. The Biloxavir is usually approved for the post-exposure prophylaxis, but the only drug in which the prophylaxis dose and the treatment dose is same. It is 40 mg single dose tablet. You got a single tablet of Biloxavir. It is 40 mg. So if you are less than 80 kg, you are given single tablet. If you are more than 80 kg, you are given 2 tablets. This is single dosage. This is a very, very important thing. So if you see the prophylaxis chart here, the Paramivir is not being used for the chemo prophylaxis. Because it is an injectable agent, you cannot give an injectable agent for the prophylaxis. So if you take the questions here, which among the following is not used in severe influenza? Oseltamivir is used in severe influenza. Paramivir is used in severe influenza. But zanamivir and Biloxavir both are usually not used in the severe influenza. But if this specific question appears in the exam, choose the option of Biloxavir, not zanamivir. Zanamivir, if they make it a little bit compatible with the route of administration, it can be approved for the severe influenza, whereas Biloxavir is preferably approved for the post-exposure prophylaxis. Very, very important thing. And the next question was, which is not used in the immunocompromised host? The Biloxavir cannot be used in the immunocompromised host, whereas the oseltamivir, zanamivir, and Paramivir can be used. Which among the following is used if the oseltamivir resistance is important or suspected? As I told you, oseltamivir and Paramivir can have the cross resistance. So zanamivir is usually given if there is a oseltamivir resistance. Pregnancy, the Biloxavir is not used, it is contraindicated. Whereas you can use oseltamivir, zanamivir, and Paramivir. And last question was in this group was which among the following is not used in chemoprophylaxis? As I told you, Paramivir is an IV administered drug, so it is not used for the chemoprophylaxis. I think I have made given some information regarding this antiviral agents. To have the more knowledge, you can go back to the literature and study. The up to date have given very nicely about the anti-influenza drugs. So again, the oseltamivir was the most preferred drug, which is available as a 75 mg capsule. For the children, it is also available as a suspension. Although it was a little bit costly a few years back, now they have reduced the price of the Tamiflu, but it's still costly. for the Indian perspective. Coming to Paramivir, as I told you, it is a parenteral. Give only for people who are not tolerate oral therapy or who are not taking orally. This statement is important here. This is many of the expert opinion, like although FDA approves it for uncomplicated influenza, it is best to reserve it for the severe influenza and use as 600 mg IV for 5 days rather than a single dose. Come to Zanamivir, it is inhaled route. So as I told you, the Paramivir is available as 200 mg per 20 ml vials. So 3 vials are mixed and given. The Zanamivir is an inhaled route. This is a Relenza. So it is not used for the patient with bronchospastic disorder, and there is a shared resistance with oseltamivir. I think I made a mistake in telling this. The Zanamivir has got a shared resistance with the oseltamivir. So oseltamivir and Zanamivir cannot be given if there is a resistance to the single agent. So drug given is Paramivir. Baloxavir is contraindicated in severe influenza, pregnant women, and immunocompromised. Although the Baloxavir had a lot of interest when it launched in 2019, but its use is being discouraged, because since we are giving a single dose tablet, there is a huge chance of having a resistance to the Baloxavir. That's why don't go for Baloxavir blindly without trying oseltamivir. So what will you do if there is a persistent symptoms, like if the patient diagnosed to have an influenza, you started him on oseltamivir and he still persists to have a symptoms, either progressive symptoms or short improvement with the worsening. So you need to suspect 2 things here. One is a concomitant infection or an antiviral resistance. So when will you suspect a concomitant infection is if the patient has an instability, either in a failure, respiratory failure, or a hemodynamic instability, maybe in shock. You need to consider concomitant infection and start antibiotics. And if the patient who fails to improve after 3 to 5 days of an antiviral therapy and supportive care, start adding in antibiotics. Because the rule is, if you start an antiviral drug, the patient will improve within 24 to 48 hours. That is a rule in influenza. If you give oseltamivir today, patient is usually fine within 24 to 48 hours. If it is not, then you need to suspect other things. And after defervescence, if the fever is recurring, then you need to go for the antibiotics. This is a very important thing. Or sometimes you might have to check for the antiviral resistance in some patients. Like there is a patient who is a contact of an influenza positive person, is a contact, and you have started him on oseltamivir as a post-exposure prophylaxis. And on antiviral drugs, if he develops a disease, this is simple to understand, not much complicated. So if you read this statement, patient who develop influenza infection while receiving or immediately following the receipt of antiviral prophylaxis with the neuraminidase inhibitor, you need to suspect the antiviral resistance. And another is, if there is an immunocompromised patient or a patient with severe influenza who remain ill despite the treatment with neuraminidase inhibitor, with an evidence of persistent influenza viral replication, how will you demonstrate this? You demonstrate that there is RT-PCR positivity even after 7 to 10 days of antiviral therapy. And you also given antibiotics is not responding, then you need to suspect an antiviral resistance. The oseltamivir and zanamivir can have a cross resistance. So the best drug to use is Paramivir. And the role of the antiviral prophylaxis, if you know, we have got 2 types of prophylaxis. One is the antiviral prophylaxis, and the pre-exposure prophylaxis. Another one is the post-exposure prophylaxis. So what is a pre-exposure prophylaxis? The pre-exposure prophylaxis is given for 2 groups of people. That means if there is an outbreak in the community, even if the person is not exposed, I want to give this prophylaxis. This is considered in 2 groups. One is a patient who is in high risk, who is not vaccinated. So if there is an outbreak, for example, presently we're in an outbreak, and there is a high risk patient, like if you have got a child or if you got old age people, you got a pregnant woman, if you got a diseased person, you need to give them prophylaxis if they are not vaccinated or if somehow the vaccine was contraindicated. And the pre-exposure prophylaxis is given for the duration of close contact or the presence of activity in the community of the influenza. Till the influenza is going on, you need to continue this pre-exposure prophylaxis. Although nobody practices it, this has been advocated by the CDC. And the drugs given for the pre-exposure prophylaxis are oseltamivir and zanamivir. The baloxavir is not given for the pre-exposure prophylaxis. As I told you, the dose is 75 mg OD and 10 mg OD for the zanamivir, and the duration is the duration of close contact. Whereas the post-exposure prophylaxis, you can give it for all the unvaccinated close contacts and all the high-risk group in which the vaccination was not given. The post-exposure prophylaxis should be initiated ASAP within 48 hours after the exposure. And if you start this drug after the 48 hours of an exposure, usually the role is very minimal. Again, the oseltamivir can be given, zanamivir can be given at the OD doses, but the baloxavir can be given. It can be either given 2 tablets for more than 80 kg or a single tablet for less than 80 kg. Very, very important thing. Last thing to know about this influenza is the vaccination of the influenza. There are many vaccines available. There are 2 major types. One, you have got an inactivated influenza vaccine. Another one is live attenuated influenza vaccine. So any high risk group or any immunosuppressed patient, the pregnant patient, you cannot give live attenuated vaccine. This is as simple as that. In inactivated influenza vaccine, there are 3 types. There are trivalent, quadrivalent. So what is a trivalent vaccine? The trivalent is the minimum vaccine we have got. They have got at least 2 strains. They have got H3N1, they have got H3N2, and they have got B Victoria. If they also add B Yamagata, it will become quadrivalent vaccine. So whatever the influenza vaccine you might have taken, if at all, they at least contain these 3 serotypes. So since it is an outbreak of H3N2, we are not expecting to have it huge pandemic because it seems that we are also already vaccinated or already have a herd immunity. But if you're unvaccinated or if you're not exposed at all, like if the patient, if you got a child, you got a very high risk, this pandemic may seems to be a deadly one. And this again comes in a different types. Some vaccines come at a standard dose. The standard dose is 15 microgram. There are high dose vaccines are also available with 60 microgram. So this vaccine is specifically approved for people who are more than 65 years. So if you are especially immunizing your grandfather or grandmother, go for high dose trivalent inactivated vaccine. So whom you will vaccinate? The guidelines say people who are more than 6 months should be vaccinated annually. This is what the CDC tells. Due to cost, etc., you may consider having high risk group at least vaccinated annually for the influenza. So when to vaccinate? So in the northern hemisphere, it is the early winter, September to October. As post October, it is going to be a flu season, and in southern hemisphere, it is March or April. So in India, which comes in the northern hemisphere, it's better to go for vaccination in the September, October, or much earlier, like August to September. So what is the choice of vaccine? If a patient is less than 50-year-old and is a non-pregnant and healthy adult, go for either inactivated influenza vaccine or a live attenuated influenza vaccine. So this live attenuated influenza vaccine is given in intranasal route. Whereas if there is an individual with more than 50 years of age, don't give live attenuated vaccine. Give any of the inactivated vaccine. You can give standard dose, you can give high dose, or you can give adjuvanted vaccine, anything. Whereas if you have got more than 65-year vaccine, you should give either a high dose quadrivalent vaccine or an adjuvant quadrivalent vaccine. So which vaccine you prefer for your grandfather or grandmother is, you want a high dose or an adjuvanted, which is a quadrivalent vaccine. I don't want a trivalent vaccine for the individual who are more than 65 years. I want to be extra cautious this. And if the patient has chronic organ disease, pregnancy, and immunosuppression, don't give live attenuated influenza vaccine. Some points about influenza and pregnancy. You know, there are some maternal risks. There is a risk of severity, a risk of transmission to the child or infant after birth. That's why post-birth, it is usually recommended of the temporary separation of the newborn, in which mother can go for an expressed feeding or an alternate breastfeeding. And there are some fetal risks. There is more risk of congenital malformation. Spina bifida neural tube defects can be seen. Remember, even if the patient does not have any influenza, just a fever in the early pregnancy is teratogenic. I think you know this or not. I just want to make this point very sure. The fever in first trimester itself is teratogenic. Any fever. Antiviral treatment. Oseltamivir can be used, zanamivir can be used, paramivir can be used, but baloxavir cannot be used. Not approved for pregnancy. It is contraindicated pregnancy. Vaccination starts as early as possible. Try to give in early pregnancy, because it is the effect stays only for a year. That's why give it for early period. And don't give live attenuated vaccine. Give any inactivated influenza vaccine. You can give either standard dose, you can give high dose, you can give adjuvanted, you can give trivalent, you can give quadrivalent, you can give anything. But don't give live attenuated vaccine. Some points about the recent advances. The only one recent advance which I want to highlight. There are many recent advances. First recent advance I want to highlight is, as I told you, all these vaccines which we are preparing or which are available, they're usually targeted to the neutralizing antibodies against the hemagglutinin, or also called as hemagglutinin neutralizing antibodies. So all these types of antigens which have been prepared are mainly situated, if at all this is a hemagglutinin structure, which has got a globular structure and which has got a stalk. This is a little bit advanced thing. So whatever the antigens which are there in the vaccine presently are of the globular head of the hemagglutinin structure. But this structure is highly variable. As I told you, there is a huge antigenic shift and drift goes on this, and majority occurs in this hemagglutinin. So this globular structure keeps on changing. So every year we need to come up with a new strains of vaccines. Now the target is to have a vaccine which is target against the stalk of the hemagglutinin. This is a little bit stable structure. It does not usually change with the change in the serotype. So this is one of the recent advances, that we are now targeting the stable region of the hemagglutinin antigen, not the variable region. This is the one recent advantage. Another one is an influenza cocktail. Although this is a very single center study, which is done in the Japan or Korea, I'm not sure, which is published in 2017 in the Chest journal. So what they tried is they tried the combination of clarithromycin plus naproxen plus oseltamivir with a standard of treatment, that is the antivirals only. So what they showed was there is a less hospital stay, there is better improvement, there is early resolution of symptoms. So these clarithromycin and naproxen, they have got an independent antiviral activity against the influenza apart from their mechanism of action. So one advice or piece of advice, although this is not a full study, this was a phase 2 study, phase 2b3 trial. So it was just a safety trial and it was a single center study. It was not a multi-center study. It was done in a single hospital and done by a very young doctor, by Dr. Hung. He did it in his third year residency. So the application of this to the practice is very questionable. We need a big study regarding this. But what I usually prefer is, whenever you have got an influenza patient, you started him on oseltamivir. Now you want to add an antibiotic. If at all you want to add an antibiotic, go for clarithromycin, 500 mg BD. Rather than choosing azithromycin, go for clarithromycin. So it may give you an extra advantage of an anti-influenza activity along with the oseltamivir and may improve the patient in a much better